Thank you. I must say this was something. So. Okay, the next presentation will be given by Professor Ariel Revel. He holds an MD from the Hebrew University of Jerusalem, and he is now the director of reproductive medicine and IVF unit at Asaf Harofeh Medical Center, a member of the endocrinology circle at the Hebrew University Medical School, manager of the oocyte donation program, and the leader of the fertility preservation program. I know that Ariel has many important positions, but the time is not afford to go on, so take the place.
So it's very exciting to stand here before of you, and there is so much students of my father and colleagues and family, and it's really a very special gathering. And I remember that a few years ago, my father and I were talking about giving my first presentation, and he even attended my first international presentation and gave me some ideas. And I told him, why don't I start with a little story at the beginning of my presentation? And I had this habit, and I tried to convince my father, and I told him a story, and actually I was very proud that one time I think I heard him tell this story. So this is the story of the deadliest hurricane in American history, and there was one single survivor. And he survived to a very old age, and when he was very old, he was, depends on your origin, but he went up to the heaven, and they said, every Tuesday we have a gathering of all the people here, and we want to ask what was your special story of your life. So he said, I made my living from going all around the United States and telling them how I managed to survive this terrible hurricane. So they said, okay, we will consult and we will think about this topic if it's a good topic. And at the end, they said, okay, we will permit it, but just take into account that Noah will also be in the audience. So you have to pay attention how you tell your story. Actually, I like this picture very much because this was I found it in some children book. And depicting Noah in this way with a yarmulke, I like that. So the definition of infertility is the inability of a couple to conceive within 1 year. Actually, this depends a lot on your geography, because when I was practicing during my fellowship in Canada, many patients arrived to see us at the clinic from many hundred thousands of miles after being treated locally by physicians and by general practitioners for a long time with medications. In Israel, it's even customary for some people to go consult some other specialties, and before they see a fertility specialist and find the diagnosis, sometimes it takes a long time. And on the other side, 1 year may be normal in the definition, but this week I saw a couple that just got married, and it's her first marriage, and she's 43-year-old. So if you tell her to wait 1 year, probably this is not the perfect idea. So sometimes it becomes that the inability to be fertile even 1 day or something of that sort. And when we see the many patients, we have to realize that even though people being barren was for many years considered a woman's problem. Actually, we face a lot of problems originating in the male. And in many couples, it is actually a minor problem, either with the male or with the female, or a combination of both. So, for example, a reduction in the probability of ovulation and a reduced sperm count will result in reduced fertility. And there is certainly many differences between women and men, and in the area of fertility, but it's very common actually today that the fertility specialist is the only specialist that sees actually a couple. And we treat the couple as a combined unit because most of the fertility treatments that we have are based on the possibility of bypassing the meeting of the egg and the sperm and through fertilization. So this is just one of the examples between the difference between male and women. I'm sure you're familiar with this, that if you give a mission to a man to go to Gap and get a pair of pants, he will go to Gap and spend 6 minutes, and the cost will be such. And whereas a female, I know this personally from going shopping with my wife, will spend a lot of time, much more money, but eventually will get there. So I'm taking this story as also a story of how infertility treatment go today, because when we see the couple, of course, we take the history and we try to diagnose whether it's a blockage in the passage of sperm or whether it's a problem with the production of sperm, whether it's a production of eggs, or whether it's a problem of transport or meeting between the egg and the sperm. But at the end of the day, the process for ovulation is very different, and we know the physiology of the ovary is very different from the testes. And what we need at the end is a sperm sample, and there is many examples where at the last moment we are obtaining eggs and not obtaining sperm, and then we are faced in problems, especially if couples have a problem with sperm donation. But if we focus on the female side, so most of the work is actually in the past been to solve the problem of a tubal factor, meaning that the meeting of the sperm and the egg do not happen because there is a problem in the tube. And one of the problems in the tube that we were dealing with in the past years at Hadassah was trying to obtain a blockage of the tubes in cases where the liquid in the tubes was actually harming the possibility of fertilization. But the tubal factor today is less of a problem because many of the issues that in the past were the result of infertility were having to do with infectious diseases such as tuberculosis, and you see it in less developed parts of the world. But actually what we're facing today mostly is ovulatory dysfunction and diminishing ovarian reserve. The main difference between the two groups is that ovulatory dysfunction is actually being very common because of lifestyle, and we're seeing many patients who are having problems to conceive because of obesity, because of inappropriate diet, and this reduces. And sometimes the only consultation that we need to give the patient is changing their lifestyle in cases of polycystic ovaries, in cases of reduced ovulation. Whereas diminishing ovarian reserve is a physiologic response to age. So as we are seeing patients come to us at a later age, we're seeing more and more problems of diminishing ovarian reserve. In fact, the year that this machine came out, and today we are, I think many of the young people in the audience are not familiar with this, but on the same year that Sony invented the Walkman, there was another small contribution to the field with the birth of Louise Brown, and I thought of mentioning it because it's exactly 40 years ago that we're now celebrating the first IVF baby. And when I was thinking of this presentation, I found this cover for Time magazine, and there was much fear about the possibilities of combination of biology, and many banned this process In fact, still in some countries, it's a very problematic issue. And this is one of the relations of this topic, and I will refer to it in the next few minutes, to my father, who became also involved in the field of bioethics, and we will hear more about it from my brother-in-law in the next presentation. And this separation between the fertilization process in the body and outside achieved many, many possibilities that we now have and did not have before. So many of the developments have been also helped by the pharma, and Merck company was one of the pioneers in this field, and many of the developments in this field are other part of the development. And whereas in the beginning there was a need for urinary products, today most of the products are being performed in the laboratory, and companies are more and more pushing us, which also raises the cost of this field. So one of the programs that we started developing is the program of egg donation. And as you can see, the main problem is that the number of eggs inside the ovary is decreasing with age. And there are less and less successes in fertility treatments on age. However, age does not decrease the success rate with egg donation, meaning that it's not a problem of the uterus. So one of the procedures that was offered, and this was one of the revolutions that we're using quite a lot now, is the possibility to freeze eggs. And committees of bioethics had to decide what would be the correct ages. And currently in Israel, it is permitted, and many of the patients that we see now come to us to the possibility of freezing their fertility potential when it's at its highest. So I looked up also regarding age 80, and I was wondering who would be, and this is actually probably this person you don't know, but at his, and he had his child at the age of 80, and you might remember him from the series Star Trek when he was younger. So being fertile at the age of 80 would be normal for men, and in fact it's quite surprising that we see many couples where the man is still completely with fertility potential, whereas at younger age, the fertility potential decreases much sooner in women. And we're looking for ways where using technology of cryopreservation would be helpful. In fact, you might be more familiar with this guy. And this is one of the characters that I know you're much familiar with. And this is him with 6 of his 8 children, with his wife Geraldine. So he managed to father at older ages. And we still are struggling with the fact that there is much of a misunderstanding about the role of age in women as compared to men. And I think a lot of education has to go into that, as we see with society. One of the fields that I was investigating very much is the fact that many of the patients are having repeated infertility failure, where embryos are being transferred to the uterus but are not implanting. So a lot of research has been done by my student Hannah Shash and Moria Kohler, and we were looking at the factors where there is a connection between the embryo and the crosstalk with the endometrium, and we were starting to take samples from endometrium and studying them for the role of ligands, and trying to test for these ligands, and today we're offering the possibility of taking this biopsy and checking which cycle is a cycle where the embryo might implant and which are not. And when we did genetic studies on these, we could see certainly genetic differences in many, many genes, as you can see deployed here in this color cartoon, between patients with repeated IVF failure as compared to controls. And these many genes have to do with the interconnection between the blastocyst and the crosstalk with the endometrium. And today there is much thought about separating, and we're going in the direction of separating the fertility process thanks to the most relevant revolution in this field, which is the revolution of freezing. So much of our investigations had to do with development and application of freezing, and I know that also in many areas now that we heard about earlier this morning, there is interest in the capability of freezing cells. It has been possible to cryopreserve sperm for many, many years using technology of slow freezing, where you decrease the temperature very, very fast. But because the oocyte, because the egg is such a large cell, this technology was not available for many, many years in women. And it's not until we started applying vitrification, where the temperature drop is very, very quick, thanks to possibilities in the laboratory to take the mature egg in a very small volume and drop it immediately in liquid nitrogen. And these cells can be kept for many, many years. And in fact, now storage of oocytes is being offered not only for patients who are in phase of losing their fertility, but also in many healthy patients, raising the hopes that they will be able to use these cells when they grow older. And while discussing this at home with my father, we decided to write a paper that deals with the question of the possibilities that are in the banking oocytes. And this gives actually freedom to women, because if you consider that until a few years ago we were only able to cryopreserve fertilized eggs, there was a problem when the couple would separate, and she would be asking, and there is stories where the legal status of the fertilized egg was at stake. So the possibility that we're offering today to vitrify the eggs and banking them is giving us new possibilities. And much of the work that we've developed and we're doing is the possibility of fertility preservation for cancer patients. So in many instances, there is a possibility to use the medications that I referred before, obtain many oocytes, and then either fertilize them if she has a partner, or freeze them, as I mentioned. However, when the chemotherapy, the cancer treatment is urgently needed, or when there is the impossibility, it's not possible to give medications, we need to freeze, and especially in young girls. And this was a work that I've done a lot with my sister at the time that we were at Hadassah, were a cryopreservation of ovarian tissue, and we developed techniques where we can use the ovarian tissue and thin it to the possibility that we can freeze it and for a few years until the child heals. And by systems that I've developed with our team and with Professor Mitrani, we've developed methods to cut the tissue and find ways that we can keep it for years and then transplant it back. And this tissue can be kept and is very, very commonly used. One particular story is our first patient, which actually didn't have malignant disease but needed treatment for thalassemia. And actually tomorrow, she's having a second child This picture was actually published on the internet as their story came out, also on television. And she had the bone marrow transplantation from her sister and healed, but became completely infertile because of the chemotherapy. She was one of the first patients that we offered ovarian cryopreservation, and when we transplanted it a few years later, she conceived and had one child, and tomorrow she's planned for a cesarean at our hospital for her next child. So I hope all this goes well. And this process of cutting the ovary revealed to us possibilities of changing some signals inside the ovary. And what we have learned is that when we're cutting the ovary very, very thin, we're actually stimulating some factors that are enabling it to become more active. So in recent years, our research is focusing more on the possibility of developing methods to using cutting technology and some other factors in order to rejuvenate the ovary, so for some cases where the ovary is not responsive. So one of the other innovations, I think, that the possibility of separating the fertilization inside or outside the body are all the huge genetic implications, and for this, at many, many hospitals in Israel and in the world, it is possible to evaluate the embryo outside the body. So the preparation for preimplantation genetic diagnosis is the most important part. We're collaborating with Shari Tzedek genetic group, and following IVF, we're doing an embryo biopsy and sending it to the lab, and we're receiving either on the same week or if it needs further testing, we're getting a genetic result. One of the ways that was used in the past was staining it. So this is a technique that is almost never used today, but just demonstrating to you that this is a trisomy by FISH technology. Today there are new generation sequencing technologies and other tests that are enabling us to study many, many diseases. And then I think in the future, these technologies will be used more and more, and we see even today that many of our patients coming to us for IVF actually are not suffering from infertility, but more for genetic purposes. So basically from this technology, you can take one single cell, and this is a test that we can do and check which of the embryos is a normal one or not a normal one. One of the special stories that we've done is this couple from India who contacted us because this story was also in the media, so all these pictures are available. So this couple contacted us for the fact that this child was looking for a bone marrow transplantation for some thalassemia problem, and they could not find in the international bank like the story that is going on now. And they came for us for the possibility of using this technology to test both that the HLA is matching, so we are able to use a donor. And this is the little brother that was born a little later. And when this picture was taken, she was already healthy from a bone marrow transplantation that was done after testing that this boy was both healthy from the disease that she has and also complete HLA matching. So all these questions are also raising the possibility of using gender, and some couples are very interested in these possibilities today to use this technology to choose the gender of, and this has also raised many, many questions because couples in some parts of the world are preferring one gender over the other. And this is just a slide showing you countries where this would be completely banned, and countries where this would be permitted. Actually, in Israel, one special committee, which I know that my father refers to in a booklet from the Bioethics Society, was dealing with these type of questions. And the formulary I think they came up with is very unique in the world. And their recommendation is that following approval from the Ministry of Health, which requires that 4 children are from the same are of the same gender, and no children of the other gender. This gives us the possibility of testing some couples which are coming to us with these questions. And another possibility which was referred to in my father's work was the possibility of using IVF for the source of stem cells, and we've heard this morning a lot about this topic. So, coming to your 80th birthday, at the previous birthdays, we have discussed these possibilities. In one of the birthdays, we even screened the film Gattaca, which touches exactly on these issues, where we're looking for a future where we'll be seeing more and more use of infertility treatments, not only for the risk or for couples with infertility, as I've referred at the beginning of my talk, but also for many, many couples who not only have a genetic disease, but are looking either to balance the family or, as we are afraid of the slippery slope, might be looking for not only a genetic problem, but also characteristics and traits. And once we have the technology, we have to be very careful about. One of the studies that we're starting now is our interest in the microbiome. So I will just talk about this because this is a study that we're starting now. And as you know, much of our body is composed of bacteria. And there is a change over our life. In fact, there is a difference that was shown between children born by cesarean and children born by the regular way as to their flora of bacteria, and even the proposition that in children born by cesarean, the lack of bacteria might impose a problem in the future, and you need to have them to have this flora. So right now we are collecting samples of microbiome from fertile and infertile women and men. And as is in other conditions possible, there are potential future treatments using stool samples as to change the flora. And we know that this has lots of relation also in fertility, in repeated IVF failure. And one of the most fascinating fields where this field is going is the possibility of technologies such as CRISPR, and at a lot of our meetings we're dealing with the possibility of using such technologies. And this, as you can see, are this is the acronym, which in short means that it is possible to use technology to change some cells, some genes in the embryo, and it might be possible or demanded in the future that we use such technology in order to repair embryos or change genetic traits within the embryo. And an embryo that has abnormal and normal cells can be directed into the way of having no such mix together. Of course, all these areas are might be risky technologies. Some of the studies that we're looking into are saying that these changes did not actually happen. And of course, once we start, and so a lot of the discussions that we're facing would be when this technology would be what we need to use. So in summary, the evolution of our field deals a lot with the research in how the embryo implants, the freezing revolution, which has the capability of offering this both to fertile and cancer patients in order to freeze and the fertility potential both for medical and non-medical, the combination with reprogenetics stem cells. And the modern era of IVF offers many, many opportunities and challenges, both in genetics, bioethics. The use of engineering in this field is one of the areas where it's developing, the involvement of robotics in order to reduce possibilities of mistakes in the lab and reducing costs, the combination with artificial intelligence and the possibility of accumulating data and learning from this, and new technologies. So I found this picture from many years ago of my father, and it's quite surprising that at this time the possibility for infertile couples were almost non-existent, and the huge revolution that has occurred. This is really an opportunity to thank both my mother and my father for the wonderful family that they have raised when they moved the family from France to here. And I know that you're very proud of all the achievements of the children and the great-grandchildren, the grandchildren, and the great-grandchildren, which are represented here. And I would like to thank you for your attention. Just to mention that all of this field would not have been possible without a lot of research as part of our work, and the combination that we've learned at home between the science and medicine is really, for me and for many, many people within the family or outside the family, a reminder, and this is my last slide, that you have to be very, very careful when you interpret results. This is actually from Alsace, where the family comes from, that they looked at the number of babies being born and the pair of brooding storks, chasidot. So they found a very strong correlation between the two, whereas there is more storks, there were more children, and they're referring from this that maybe, so we know that today, as I spoke about, we can really look to the future and try to offer many, many possibilities for infertile couple. So thank you very much.